Do you want me to do this whole thing here?
To introduce Dr. Reddy.
Yeah.
You don't have to. You can.
Okay.
Okay. All right, let's go ahead and get started. So today we have two guests. We have our main speaker, and we also have Anna, who is a student, who's actually a participant in this class, but she's been working closely or kind of simultaneously with Dr. Reddy at the Veterans Affairs Office. So I'll let her talk for a few minutes, and then we'll have our main speaker right afterwards. So this is Anna. Can't find the mouse.
Hello, so I'm Anna Ribich. I'm a Doctor of Nursing practice student here in the Family Nurse Practitioner program. And I have had a consistent clinical rotation at the VA for the past 2 years. And while doing that, then I just noticed the high number of homeless patients that I had in the clinic or people who are at risk for homelessness. So I decided to do, or to focus my doctoral project on the coordination of care for homeless veterans. So I was connected with Dr. Reddy and the H-PACT team, which is the primary care team that focuses on the homeless population specifically. So currently I am helping them gather information related to the Community Resource and Referral Center that they're hoping to, or that they will open in Seattle in 2014. And what that is, or how that was started, in 2009, then President Obama and the VA Secretary Shinzeki declared the initiative to end homelessness for veterans by 2015. And I've learned through this the importance of goals that may not be reached, but just to declare the goal really helps to get things going. So a lot of funding and awareness was generated through that declaration, and things like H-PACT and the CCRCs are being started now. So community resource and referral centers, they're supposed to be a one-stop shop for homeless veterans. So easy access to resources both at the VA and in the community. It's supposed to be a welcoming environment, a place that they feel comfortable coming to. A lot of the veterans don't feel comfortable going to the VA as it reminds them of their past service, or they just physically aren't able to get there because it's not located where they are living or staying in the streets. So this center, we're going to be opening it in probably either Pioneer Square or the downtown area. And it's going to be multidisciplinary and multi-agency center. So they'll have housing services, healthcare services will be located at the center, such as primary care, mental health, and I'm not sure about dental services at this point, but that is one of the number one needs in the homeless population, in the veteran population who are homeless, and probably the homeless population in general. But so they will also have vocational training programs and just easy access to VA and non-VA benefits, and a number of other services such as laundry, showers, food, computer access, coffee, probably community resources. So there are 17 centers that have been opened nationally within the past 2 years, and that's just a list of where they're located. And now Seattle is next on the list, so they will hopefully be opening in 2014. And that's all that I have for you today. So now I'll introduce to you our main speaker, who's Simha Reddy. Dr. Reddy serves as the director of the Homeless Patient Aligned Care Team for the Puget Sound VA Healthcare Services in Seattle. He helps provide primary care and outreach to the homeless veterans throughout the Seattle area. His interests are to improve access to health care for the underserved, HIV primary care, and medical education. He's a graduate of Washington University and St. Louis School of Medicine, and he recently completed his residency through the University of Washington School of Medicine in Seattle. So here's Dr. Reddy.
Anna, thank you so much.
all of yours.
Oh, great. Well, first of all, I just want to thank all of y'all for having me here. This is just really exciting to see an entire class devoted to this issue around health and homelessness. Just to get a rough sense of things, how many of you are here from the dental school? Right. How many from social work? Housing? Or, I'm sorry, nursing? Fantastic. Anybody else? Medicine? What else? Well, I'm really excited to be talking to y'all, and I think the need for dental care in particular is enormous among this population. But what I'd like to do today is, and just to give you a little bit more background, I'm actually pretty brand new to this job and to this issue, in fact. I graduated from the University of Washington Internal Medicine program just last spring and have joined up here at the VA in August. And so we've known this about 8 months, so I'll give you my impressions so far, okay? I'd like you to come away with just 3 things from this talk, all right? Number 1, our veterans, the men and women who've served our country, make up a disproportionate share of the homeless population in this country. And number 2, that homelessness destroys lives, it kills people. This is something you've seen through the classes you've already had to date, but I'm going to touch on that briefly as well, that it's a two-way street. Homelessness worsens your health, and poor health leads to increased rates of homelessness. And we'll just talk briefly on that issue and kind of why that's the case. And then finally, I want to talk a little bit about what the VA is doing. This is the third point, that this is a really critical time right now, and I mean like right now, that on reference this briefly, 5-year plan to end homelessness, that with the goal of ending homelessness among veterans by 2015. And right now is the time that we have the resources and to make this happen. So I'm really glad this class is happening now, and I hope that y'all continue to pursue this in the future. But just in this little talk, we'll talk a little bit about the scope of the problem. This is something that you've already addressed to a great extent, I'm sure. Homelessness generally, the interaction between health and homelessness, some of the barriers to care, some obvious, some not so obvious. A few of the interventions from the, unfortunately, scant literature on interventions that improve the health of folks who are homeless. And then finally, what we're doing at the VA. So, thinking about the scope of the problem, as you're probably already aware, the statistics surrounding homelessness are terrible. It's hard to get counts, right? It's hard to get a good sense of the actual numbers. And because you can't just call everybody up on the phone and ask them in a survey, are you homeless or not? That's not necessarily going to work. You can't go knocking door to door. And so to get a sense of the rates, we have to do things like the one-night count. Everybody here familiar with the one-night count? Okay. So just on the off chance somebody here hasn't heard of it already, this is the yearly point-in-time count where folks go out in the middle of the night, 2 to 5 in the morning, something along those lines, to get a sense of who's out on the streets in cars and shelters and whatnot. How many of you participated in the one-night count this year or in previous years? Fantastic. This picture actually is from Seattle. I love the Made in America sign on there. It's pretty terrible. This is just a quick summary. You may have seen this data already. But this past year, there were a total of about 2,700 people out and about the streets of Seattle. This is a time when, David can probably tell you, it was pretty cold that night. I think somewhere in the 30s was a low that evening. By the way, to give you a sense of sort of VA efficiency and bureaucracy, it's kind of too bad this is being recorded, but where would you, if you were going to choose one place in Seattle or in the King County area to place a resource center for homeless veterans, where would you put it? Probably not in Renton with its 83 homeless folks, but that's where our current base of operations is for our housing initiative. And there are various reasons for that, but it's something we're trying to correct. And then just to remind you that if you take into account everybody was homeless that night, not just folks on the street, but folks in shelters and in transitional housing, the number jumps up pretty dramatically to over almost 9,000. And to get your blood boiling a little bit, if veterans aren't enough to get you excited, there are 1,500 of these folks were under the age of 12, and then 216 kids in a separate survey that were turned away from services in overnight shelter that night. A little bit more in the way of numbers. When you're thinking about the best data we have to go on are these point-in-time counts, right? And when you aggregate the data across the country, you get about 630,000 people. Between 10 and 12% of them are veterans. And then it breaks down into sort of the chronically homeless, a couple other subcategories there. One thing that you all may be aware of already is this distinction between what it means to be chronically homeless and homeless. A much greater number of people experience homelessness during a year than are chronically homeless for years and years. The sort of mental image you come up with when you think of a homeless person, at least before taking this class, I imagine, is a person standing on the street corner with a cardboard sign who's been there for years or months at least. But that's not necessarily the typical picture. And it's not as though everybody on the street is someone with mental illness or drug abuse. Obviously, these are at higher rates in this population, but certainly not everybody. Now, coming to veterans. This is really sad, but veterans are overrepresented within this population. That estimates vary quite a lot, but inevitably you find rates that center around the idea that veterans make up maybe about 8% of our population, but about 12% of the homeless population. And that if you're a veteran, your odds ratio of being homeless go up by 50% to twofold even. And among women, that's even higher. So I find this number particularly shocking. The 1 in 10 vets in poverty experience homelessness. 10% of veterans who are in poverty who disproportionately use a VA experience homelessness at some point, just within the last year. And when you look at sort of the demographics of it, it tends to be older male veterans, folks in their 40s to 60s, and younger female veterans in their 20s to 30s, or generally in the 20s. By the way, feel free to stop me anytime for questions. And but 63,000 veterans across the country seems like a huge number, an incomprehensible number, at least to me. But when you start taking it down to the local level, well, that actually means about a little over 1,000 homeless veterans. It gets a little bit more manageable, something you can sort of wrap your head around. And about a quarter of these are chronically homeless. And again, in this population, a homeless person who's a veteran it's more likely that they will be chronically homeless than someone who's not a veteran. So chronic homelessness is at a higher rate among the veteran population as well. But by the way, this number is a little bit just like a lot of numbers around homelessness, not really solid. I talked about sort of the 12% number, but when you ask around at different shelters in the area and their sort of internal numbers, you get ranges that go from 10% to 14, even higher than that in terms of people self-identifying as veterans, which, by the way, is an important distinction. If you just go up to somebody and ask them, are you a veteran? You may not get the full story, because there are people who've served who may not consider themselves a veteran. And the reason for that may be they served in the National Guard but were never activated, or they were activated for a brief period of time, or never served in a war itself, and so may feel uncomfortable with the idea of being a veteran. Or they were discharged maybe not under optimal conditions, and so don't feel like they classify as, or they don't self-identify as veterans. So in fact, there's a program called the Veterans Interview Project. Has anybody heard of that? So this was an offshoot, actually, of the point-in-time count, the one-night count. So just as you were finishing up, Dave, I sort of finally got up and got out the door and went to, along with a number of other veterans, to a variety of shelters and drop-in places. And for the next several hours, asked everybody walking in the door have you ever served in the armed forces or National Guard? Were you ever activated? And do you participate in the VA? That sort of thing. Just a couple of quick questions, and the numbers range around the same, though, around 12, 14%. So when you think of a homeless veteran, what image sort of comes to mind? And for a lot of you, it may be the image that I showed earlier or that Anna showed earlier, the person with the cardboard sign, somebody sort of a Vietnam-era veteran. But this is certainly not everybody. And if you're sort of mathematically inclined, you might start thinking about it in terms of numbers. So homeless veterans are sicker than the average patient or veteran. And I use, by DCG, I mean diagnostic cost groups, just a way of measuring a sense of how many problems do they have on their problem list, how many issues do they deal with, how many times are they admitted, that kind of thing. They're more likely to have a chronic medical condition of some kind, more likely to have some sort of substance abuse history, and this number, 80%, varies a lot. But certainly above half, roughly around 60 to 80%. A very large number who suffer from post-traumatic stress disorder, and not necessarily from combat. You sort of think of PTSD as, it's got to be a firefight kind of thing, but that's not necessarily true. People live under stressful situations for a long period of time, undergo stress from not just combat, but the stress of service, the stresses from prior to their life. In fact, I have a large number of people who, of veterans who have suffered from military sexual trauma and have PTSD as a result of that. Childhood trauma, either physical or sexual, and still suffer from that. So PTSD does not necessarily just mean, what you might classically think of. And then a large number with some number of psychiatric disorders. So depression is huge. Either a cause of their homelessness or vice versa. About half of my patients carry a diagnosis of depression. And then things like other mood disorders like schizophrenia, bipolar disorder, certainly at higher rates. And I also want you to keep in mind certainly there's less employment, but it's not as though everybody who's homeless is unemployed. In fact, I was seeing a patient in clinic just the other day who lost a job, late 30s, lost a job in which he'd been some sort of computer programmer or something in the tech industry, was divorced from his wife, but had a good relationship with her and had been providing child support to their daughter. But after losing his job, he wanted to keep maintaining those same child support payments. He didn't want to go to the judge and bring it back down again. He wanted to make sure he felt like he was a provider. So he ended up getting 2 manual labor jobs, would walk to work each way 40 minutes so he could save on bus fare, was living in a tent down in Kent because he couldn't afford housing. And the only reason that I ended up meeting him was, and doesn't drink, doesn't use drugs. His only vice is a cigar every week. So working as hard as he possibly can, trying to support a family, and still homeless. So there are as many ways to become homeless as there are people who are homeless. And the reasons why people become homeless, at the end of the day, it's because you don't have enough money for a place to stay. But inevitably, the thing that leads you there is some sort of crisis. And it's a family crisis, a divorce, or a death, some sort of economic crisis where you lose your job. Drugs and alcohol certainly play a big role here. And it can be, you can certainly get into a spiral there where one crisis leads to recurrence of your drug or alcohol, or relapse of your drug or alcohol problem, which makes the whole thing that much worse. And then mental health crises. I was talking to one of my vets the other day who's finally now in stable housing, and in his case he'd actually been in housing for some time and been doing okay, but every couple of years he would just fall off the map. And I started asking what was going on. Is, every once in a while my bipolar disorder starts getting a little worse, or I forget to pick up my meds or something. and I'll start going into crisis. And I can't really get it together enough to go in to see the doctor, or I call them up and they say it's going to be another couple weeks, but I can't wait a couple weeks. Something is going, like, things are going wrong. And so he's just like gotten up and walked away from housing, multiple times, and had everything just fall apart on him. And it took having a caseworker who sort of recognized that this was the issue, that he needed somebody to whom he could turn at the drop of a hat when things were going badly, to be able to avoid the same sort of perpetual cycle. So now he's in a housing environment, has a case manager that he can call. He's got a mental health team that he can turn to whenever he's feeling poorly and getting back on track. But large number of reasons why people can become homeless. It's a two-way street, as I said. First, sort of, how does poor health lead to homelessness? Well, this is pretty clear. You've got worse mental illness. You've got higher rates of substance abuse, and that leads to poor decisions that lead to the sort of crisis that leads to a loss of housing. But then other things that I think are maybe a little less obvious: traumatic brain injury. So a lot of our veterans that come back with traumatic brain injury, folks who in previous wars may not have made it back, but thankfully are still suffering quite a lot from their experience during combat. But even aside from sort of combat-related trauma, there's a number of people who've had motor vehicle accidents and other sort of traumas that have led to traumatic brain injury who subsequently become homeless. And higher rates of mild cognitive impairment. And I think this is going to become more and more apparent as our baby boomer generation grows older, that folks who are doing okay at the moment, who are getting by with a little bit of maybe a little bit of support from family or friends, who've settled into a nice stable life, but who maybe are slowly starting to see the effects of dementia or some loss of cognition. Well, when the next crisis comes along, they may or may not be able to deal with it. And then an 83-year-old woman at the Downtown Emergency Service Center on Wednesday, who, not a veteran, but she started talking before I could, and started telling me her story. And she had been living in stable housing for a long period of time, went in to get cataract surgery, paid out of pocket for a bunch of eye drops of some kind, and didn't have enough money to make the rent, so just didn't pay any of it that month. And then tried to come up with some sort of negotiated plan with her apartment manager, but it all sort of fell apart because she wasn't able to make a court date, and then one thing led to another, and all of a sudden she's on the street, and her items have been repossessed, and she's 83 years old and has nobody to turn to. And that's the kind of thing that shouldn't be happening. And if she'd maybe been just a touch sharper or a little less, weakened from all the surgery she'd just gone through, maybe she could have put up a better fight. But now she's sort of stuck in this tougher environment, and it's even more difficult for her to get the care she needs and the help she needs. And then sort of disabling, bankrupting medical condition, just like I talked about. Certainly one bad fall or bad medical condition can deplete somebody's savings pretty quickly. And then the other way around, how does homelessness lead to your poor health? Well, in a host of different ways. This morning I was taking care of a man who got his jaw broken in the middle of a fight at a shelter. And both men and women suffer not just from physical traumas, but sexual assault at much, much higher rates than the average population. Certainly, I think you heard from Doug Powell last week about sort of the infections and dermatologic issues and foot issues that face those who are homeless. Rates of things like tuberculosis, Hep C, HIV are higher. I have a separate sort of clinic just in HIV care, and I've been shocked that I'm seeing almost as many, well, it feels like I'm seeing as many HIV-positive patients in my homeless clinic as I am in my regular clinic, which is really sad. insecure and unhealthy food. When you're diabetic and somebody offers you a Danish, what are you going to say? No, I'm sorry, I'm going to go hungry for the next 12 hours instead. No, you're going to take the Danish, and maybe you've got insulin, maybe you don't. You don't have nearly the kind of control over your environment that you would if you were living at home and taking care of yourself. And the worst thing is mental illness. If you can't make it up to pick up your medications, if you are dealing with the stress of being in an environment that's unfamiliar, all of that's going to worsen your mental illness and potentially trigger either relapse or worsening of your mental health or substance abuse issues. And talked very briefly at the very beginning about how homelessness kills people, and it's true. How many people think the mean age of death of the homeless here in King County is 47? Got a couple hands for that? 57? 67? All right, all your test-taking skills, right? Everybody goes for a B, but in fact, it's actually 47. This is replicated on in a number of different cities. People looking at autopsy results and finding that people died at much, much earlier age than they should. I mean, this is the 47's the expected life, the life expectancy of somebody like born in like 1900. This is not what somebody in a modern era should be living to. And if you look at sort of more prospective studies that are where you just take a cohort of folks and watch them over time, it tends to come out with a median survival rate in the 50s or so as well, but certainly not the 75 kind of thing that we would see in a typical population. So think about barriers to care. There's a lot, and some of them are obvious and some of them aren't, and I just want to go through a few of them, because I think there's sometimes a tendency to think to ourselves when somebody comes in with a problem that clearly has been getting worse for a long time, like, why didn't you just go see your doctor? Why didn't, like 2 months ago? Why'd you have to show up here now with an abscess that's the size of a golf ball or softball or whatever it is? And I think the issue is to try, I mean, it's really hard to put yourself in somebody else's shoes. And I find myself doing it every single day and I still find it very difficult. So this is a patient of mine who actually is rehospitalized right now, but a 52-year-old gentleman. He's got a long-standing history of cirrhosis, but he's clean from alcohol. He's totally sober, but with a lot of complications associated with his end-stage liver disease. He has ascites where his belly just blows up with fluid. He's got hepatic encephalopathy, so if he doesn't take a medication called lactulose, which basically gives him the runs so that to get rid of some of the various toxins that would otherwise make him confused, he will end up entirely delirious. But he made a decision to move all the way here from Spokane, where he had some minimal support out there, but he came to follow his heart, you know. And he gets here and he finds out that she's using meth, and he's a recovering meth addict. And at this point, if you were to come into your clinic and say, "Doc, what should I do?" and his only two choices are go stay with the girlfriend who's using meth, or go to a shelter, what are you going to do? I mean, well, no, don't use meth. Obviously, that's a terrible thing to do. Go to the shelter. So it's very reasonable for him to go stay at a shelter. And let's say you decide to go stay at the Union Gospel Mission, which is a wonderful place. I mean, the folks who live there, who operate that place, are just fantastic and really open their arms wide to folks. But it can be sometimes a rough place to stay. And so he goes to the UGM, and he realizes there's only one bathroom, and it's not exactly the cleanest thing in the whole world. And he's got a couple choices. He can either take the water pills that are going to make him pee like a racehorse all day long, and take the lactulose that's going to make him have bowel movements at least 4 or 5 times over the course of that day, and I mean runny ones, and have somebody else who he's just met just watch all his stuff that he's been carting around. Or he can just hold off for a day or two on the medications and just try to get by. It's fairly reasonable for him to want to stay comfortable for a minute. But let's say he does. Let's say he holds off on the medications and he starts to swell up with fluid and his legs get swollen and he scrapes against something or other and he gets a terrible infection. You've got a couple options, right? You can call the VA. You can spend about, I put 10 minutes on here, you can call the VA and you've only got a few minutes left on your phone, and you can spend half of it on hold and half of it get an appointment for another 2 weeks out, and then you can't call your daughter because you have no more minutes left, or you can just go to the emergency room. Well, I mean, the choice is obvious. If I were him, I would definitely go to the emergency room, right? Like, why would you bother with this rigmarole of like trying to get an appointment for whenever? And in fact, this is kind of I took it easy on the VA here. I tried calling myself through the main clinic line that we give out to our patients, and I spent 23 minutes on hold before being told that I could call back the next day if I wanted to leave, or I could leave a message. So, there's a lot of systems in place that keep folks from accessing the care that you would want them to. So he does what we wish people wouldn't do and just go to the ER for something that could totally be treated in an outpatient setting. And somebody takes care of him there. They drain an abscess, they give him some medications, and tell him to go follow up with your doctor. But you're already at home, and the ER can't get in touch with you when they realize that antibiotic's not going to work. And you're just sitting at home getting worse and worse. Your infection's getting worse. You're getting more confused because you're not taking your lactulose. And eventually, somebody takes you into the hospital. And of course, you go to Harborview, because that's where everybody goes. And you finally get stabilized and discharged, but by the time somebody finally gets around doing all your paperwork, because there's a lot of it, all the shelters are full, and you go back to the street. And now, what are you going to do? You go back to that girlfriend who's using meth, or do you go back to UGM and start the whole thing again? These are tough choices that people face, like every single day. And just to list them out a little bit, communication is a huge barrier. It's so hard to make sure that you've got a solid way to get in touch with somebody. I draw an HIV test. I need to be able to give those results to them. And if you don't have a phone, or if you don't have minutes on your phone, maybe you've got a community voicemail, but you don't have access to a phone to access that voicemail. Well, it can be tough. And you say, well, why don't you just go to the library and use the email? Well, some of them can't. Some folks can. Some folks can't. And your time on that is limited as well. Transportation is tough. How many of you, do you guys remember when the ride-free zone closed down here in downtown? Yeah, so that was a real inconvenience for a lot of folks, right? You can't get up and down the streets. But the homeless population, that was really a body blow. Like, you can't get to see your case manager. You can't get up to the federal building to get your ID. You can't do a lot of things that you used to be able to do. And are you going to pay $225 to, go 10 blocks? I don't know. Probably not. You're probably just going to skip it. Care is fragmented, kind of all over the place. You see Harborview, you see the VA, you see Highline, you see Valley, and nobody's records talk to each other. And it's really hard to comply with all those wonderful recommendations that your doctor gives to you. You're like, well, keep that 2 grams, don't take more than 2,000 milligrams of sodium in a day. And you go to the food line at the shelter, and it's mashed potatoes and gravy and fried chicken, which is delicious, but has a lot of salt to it. And put your foot up. Get rid of the swelling in your leg. Well, where are you going to put your foot up? You got nowhere to sit. Somebody's just going to come along and yell at you. Health illiteracy. I think this is something that is a broader problem than just among the homeless. I mean, just asking about, how many of you have asked about literacy among your patients that you've seen in dental clinic? When you're writing, I imagine you write out instructions every once in a while, right? Say, rinse your mouth or whatever it might be. How many of you has anybody ever asked about literacy? Okay. You might be surprised, actually. I didn't start doing it until about a year and a half ago, and I was shocked that I ended up picking up folks who were illiterate or barely literate, or if they were literate, had no idea what I was talking about when I'm referencing all the medications and how often to take them and that sort of thing. And by the way, the way I usually do that is as I'm writing my instructions down, I'll ask them, by the way, do you have any trouble with reading or writing? And that can be vision or whatever, however they want to take it. But don't be afraid to offend somebody in trying to give them good care. There's a lot of stigma and mistrust. People, when you're the guy walking into the emergency room with just blood pressure that hasn't been treated, the doctor who's going to walk in there is going to be somewhat exasperated because they're already seeing 4 other heart attacks and a stroke and a motor vehicle accident, and this guy is just walking in and using my ER space, and you don't necessarily get it's easy to get inpatient care. It's easy to get care that's not as empathetic as it should be, and not because people are trying to be harsh or bad. They just got to make priorities, and it feels terrible when you feel like you're always at the last of everybody's list in terms of priorities. The guy I was talking about with the broken jaw, we finally got it arranged so that he could get his jaw fixed up at Harborview through the OMFS clinic there, and he actually has an infection in the jaw and really needs his hardware taken out. And he went in there at 6 in the morning, and by noon he hadn't been seen yet. And it wasn't because people were trying to push him to the back of the line. It was because they had more urgent cases, and he just kept seeing these more urgent cases go by. So 6 hours later, he just gets up and goes. He pulls his IV out of his arm and then leaves and comes storming back into my clinic saying, they don't care about me because I'm homeless. That's probably not what the case was, but he's had enough bad interactions out there that's how he interprets it. And so there is some mistrust. Also, when you're a vet and you don't want to show up in the waiting room smelling because you haven't taken a shower in 3 weeks, and you're surrounded by other Marines around you, and 2 may or probably didn't serve with you, but might have, and you can feel a little stigmatized sometimes. And then making appointments, it can be tough. It can definitely be tough. Trying to make an appointment 3 months out when you don't know where you're going to eat or sleep that night. So I kind of tend to ramble, so I'm going to kind of rush through the next little bit here. But so in terms of interventions, there's not a whole heck of a lot of great evidence for really effective medical interventions. But case management tends to be one of the big categories that really hooking someone up with somebody who's going to watch out for them can make a big difference. In this particular study, they took folks who were in shelters and about to transition into more permanent housing, but who suffer from mental illness, and hooked them up with a kind of a peer support person who was picked for their street smarts. I swear, this is what they said in their article. They were picked for their street smarts. I don't know how you measure that exactly, but that person with street smarts would just check in with them all the time, make sure that they were doing okay, that they got furniture in their house, that their mom knew where they were living and would check up on them. Basically try to get them, rebuild that support network that we all sort of take for granted. And in this case, they were able to improve the ability of folks to stay in stable housing. You guys all know what this place is, right? Everybody's heard of 1811 East Lake? For those of you who haven't, sometimes called a wet house or a home for chronic inebriates. This was a huge success story. Seattle-King County put all got all the providers in the area to put together a list of the folks who cost the county the most money, and inevitably they were all people who drank. It was alcoholism that was costing the county the most. And so they said, you know what, let's take all the money that we're spending on that and build some housing for them and hand them the keys. And that's what they did. And you didn't have to be sober to get in. You could just show up and get a place. And it ended up saving the taxpayers enormous amounts of money. It dropped from, close to $8,000 a month that people were spending per person, down to around $2,000 a month, $3,000 a month per person. That's savings from sobering centers, detox centers, ambulance rides, medical care, etc. Jail time. So case management, housing first, and then finally, this is kind of where my bread and butter is, homeless-oriented sort of primary care. Having folks who are dedicated, it's a little bit hard to read, but the idea is that they set up a clinic specifically for homeless veterans out in, I think this is Providence, and made an effort to really see them really frequently. It wasn't just come back in 6 months, it was come back in a month or a few weeks, and we'll just keep checking in with you all the time. And that sort of upfront investment by people who were attuned to the special needs of this vulnerable population helped reduce things like the number of ER visits and admissions for medical issues, not necessarily overall, but just at least among medical issues. But I want to talk real briefly about the VA and why this is such an important time right now. So back in late 2009, Eric Shinseki, who is the Secretary of the VA and former Secretary of the Army, came out with a statement that he and President Obama were committed to ending homelessness among veterans within the next 5 years. Just ending it, period. Like, there should not be any veteran living on the streets. And when I first heard this commitment, I thought it was ridiculous and started laughing. I thought this was crazy. And it is really ambitious. I think that's true. But I think it is, I've been doing this for about 8 months now. I think this is achievable. I think we have to choose to believe that this is something that we can do. Because I agree, I don't think anybody, no matter what poor decisions they're making, deserves to spend a night sleeping on a park bench when it's 20 degrees out and not having enough to eat in this country. So I think, and as a result of this commitment, the number one priority for the VA right now is ending homelessness. So every new project, every dollar that's spent at the VA, you first got to ask, is this going to in some way help end homelessness among veterans? And, most things they're not, but we always got to keep that in mind when we're coming up with projects and care plans. And a few of the different ways that the VA is doing this. One, it's pretty straightforward. People are homeless, you give them housing. And this has been by far the biggest portion of this commitment. We have increased funding to something called a grant per diem programs, where you pay a program like a shelter like the Salvation Army's William Booth or the Compass Center every day that a veteran is staying in one of their beds. And that is very clearly helps people get off the streets in a quick manner. For longer-term housing, there's a program that's a joint program between the VA and the Housing and Urban Development Department, in which veterans can get subsidized housing for, I think, 1 to 2 years, something along those lines, where we'll take care of the rent or a good portion of it while folks get back on their feet. And that's just, you go out and find a regular apartment on your own with this voucher in hand, kind of like a Section 8 voucher. And then the final thing, this is what I'm doing, is something called a H-PACT. The VA loves acronyms, so this is the Patient-Aligned Care Team. Basically, it's just a primary care team, a medical home for the homeless, you might say. And it kind of got rolled out across the country, 32 different sites. 17 of them have these community resource centers, with the idea being that we would focus efforts on this very vulnerable population to make sure that folks had the medical and psychiatric stability to succeed in housing. Because it's not just getting a place to stay, it's also making sure that you're not going to fail out of that again for whatever reason, either because your psychiatric disorder is not fully taken care of, or your COPD gets so out of control that you end up in the hospital all the time. And a few different ways that people have approached this, and every site has done this differently, because we honestly don't know what the best approach is yet. One is to create something called like a community resource center that Anna was discussing, a one-stop shop where you come in for your housing issues, your psychiatric issues, your medical issues, everything. Now there's just sort of intensive case management that you have social workers who spend an inordinate amount of time with folks, walking them through the steps that are needed to succeed. For example, we've got this gentleman who lives in a shelter downtown who is legally blind, suffers from a variety of delusions, and was homeless and penniless because Social Security had basically lost track of him and assumed he, and so his checks have been piling up somewhere, and he had just gotten up and left one day from wherever he was staying at previously. And our social worker has spent days walking him through the process of getting identification again, and then talking with Social Security, and getting him housing, and getting him reestablished, and convincing him to come to see the ophthalmologist. And it took a long while. It took building a relationship. It wasn't, these aren't the kind of things you can do in half-hour sessions. And then a variety of other things like focusing on walk-in clinics as opposed to making sure everybody's got an appointment. Co-locating with the ER. We haven't done that here, but it's been successful elsewhere. That as somebody walks into the emergency room, they're asked if they're homeless and it's a non-urgent issue, they can transition off to this primary care team as opposed to waiting for 6 hours in the ER. And then do an outreach, which is something that we tend to focus on here in Seattle, going to a variety of different shelters and such. Let's talk about sort of is this an achievable goal? And this is part of the reason why I think it is. Sorry. That's an awesome ringtone, or whatever that was. This is why I think it's achievable. That we're talking about hundreds, not hundreds of thousands of people. We're talking about hundreds of people that we can take care of, and I think that's something that we can do. Just to give you a sense of what my day-to-day is like. So a couple pictures from kind of the places we visit. The place on the left is the urban rest stop. We go to hygiene centers like that, like the Compass Hygiene Center, once a week, which provide laundry and shower services and hygiene services to folks. Just asking if anybody wants to see a doctor or a nurse or a social worker, and oftentimes pretty successful. In the middle is the banking and mail window over at the Compass Center, where folks who don't have a permanent address can still get mail. And then just a reminder that when people are homeless, they're not just homeless at night, they're homeless 24 hours a day. And finding a place just to sit down and relax for a minute is an incredible luxury sometimes. So when we think about homelessness, it's not just a bed at night, it's what are you going to do all day long? A number of shelters I go to look very similar to this, where you have a mat on the ground for the night, and or maybe you get a bunk bed. This is more like the DSC, and the other is more like the Union Gospel Mission. And we work with a number of community partners, and they have been absolutely essential to really helping our program succeed. They call us when they've got somebody that they're worried about who's a veteran, and we come down to visit with folks. We go all the way as far south as Renton, as far north as Everett, and every time we go to these places, we tend to find somebody who is not connected with the VA yet. Union Gospel Mission, Compass, 1811. This place down here in the bottom is a place called is a transitional house built by the Compass Lutheran Church, or Compass, Housing Alliance. It's up in Shoreline, and it really is a spectacular place. It feels like a dorm when you walk in. It's warm, it's welcoming. People are really, they have a little garden outside where everybody gets a plot to grow their own stuff, and it makes a dramatic difference for folks. And then HUD Bash. Here are a few of the community resources that are out there. And this is kind of what our team looks like. We got a doc, a nurse, social worker, and we essentially provide a medical home. Looks like we're about finishing up here, but this is why we do what we do. I've heard these exact words come out of people's mouths, I don't know, a dozen times now, it feels like. I don't want to think about that. I'm in survival mode. I don't want to just don't talk to me about that. I'm in survival mode right now, and our goal is to try to get them out of survival mode. And I'll skip this for now, but these are some of our first results. When we take a look at our first cohort of 137 folks and look in the first 6 months, prior to starting with us and 6 months after, we've seen a pretty dramatic reduction in ER use and hospital admissions, which we think is a good proxy. Well, it's the only proxy we've got for whether or not we're helping stabilize folks, and we think we are. A lot of stuff to continue doing in the future, but I want to make sure we have a little bit of time for questions. Actually, one other thing about the one-night count, you guys may already be aware of this, but I think one thing that's particularly notable about this one-night count was this was the first night that somebody was found dead, on the street. And her name was Catherine Ann Blair, and she died of hypothermia. And this was a woman who, based on the eulogy provided by a friend of hers, had been doing great, graduated from college, and then developed a severe mood disorder. And eventually stabilized, lived with her mom for a while. But when her mom died and she lost her support, she ended up doing very, very poorly and becoming homeless. And this is the kind of thing we're trying to prevent, and I'm glad you guys are as well. But thanks so much, guys. I'm sorry I missed the conference. I'll just hang around here if anybody's got questions.